Good afternoon, and thanks for joining us for today's Healthline. Healthline is where we like to focus on ways to live a healthier, happier, and pain-free life. I'm Courtney Butts, and I'll be your host today, and we'll be taking your calls and answering your questions live in the studio. We'll be opening the phone line soon, but as a reminder, please make sure you're in a quiet room when you call with your TV turned all the way down so that we can hear your question. Our number is 318-219-4569, and today we are talking about genetic testing for hereditary cancer. And joining me today to talk about this important subject is Dr. Mary Nordberg with Willis Knighton Cancer Center. Good afternoon, and thanks for joining us.
Good afternoon. Thanks for having me, Courtney. I appreciate it.
Yeah, well, I'm excited to talk about this. Cancer is, really scary diagnosis, and it's Colorectal Cancer Awareness Month, March is, and so we're going to be diving in on why this is important to maybe come see you beforehand for genetic testing.
Absolutely, 100%.
Yeah, so tell me a little bit about hereditary cancer.
So hereditary cancer is only a small piece of the pie. So obviously cancer is a scary diagnosis. We actually try to identify people who might be at hereditary risk. So family members, so the way it works is that if you have family members who have cancer, multiple cancers in your family, multiple generations that have cancer, we try to identify those people because the goal is really to, before you have cancer, let's say John Doe, before John Doe has cancer, John Doe may be from a hereditary cancer family, and we want to say, okay, John, you are at risk here, and we're going to put you in a higher screening. Now, your genes are your genes. You can't change them. It's the reason we look the way we do, and the way we're not how we want to look, but the way we are. So you can't fix it. But if you know that you have a gene that causes or predisposes you to cancer, then we will surveil you or put you in a higher surveillance thing. So you're not general population anymore, you're high risk.
Right. And you are typically high risk when you have that family member that has
cancer. You may be at high risk and never have anything, but it's a numbers game that you play. So if you have a gene, for example, that predisposes you to colorectal cancer, you're not the average person. You're not the person that gets Cologuard. You're not the person that starts screening maybe at 45. You might start at 30 if you have a predisposition gene. And those are the things: breast cancer, ovarian cancer, colorectal, it's all included.
Right, yeah. So are there any specific cancers of concern that more than others for hereditary cancer?
So it's really, there's 8. So I'm excluding all the pediatric cancers with leukemias. So it's the 8 primary organ cancers. So the breast, the ovarian, the uterine, the colorectal, the prostate, melanoma is another one we don't typically think about, and then obviously prostate for males, and stomach cancer. Stomach cancer, again, as y'all know, Toby Keith just died of stomach cancer. Stomach cancer is very difficult to detect. So we do genetic testing for the 8 primary solid organ tumors that may, through clinical based evidence, we know now that there are genes cause and effect. If you have gene A, it causes this. If you have gene B, it causes this.
Gotcha.
And those are the reasons.
Yeah, so tell me a little bit about what we're seeing on our screen
So
here.
if you look at the graphic, I mean, the questions that a lot of my patients ask, even if they've already had cancer, is why should I investigate further about what causes cancer? So if you look for colorectal cancer specifically, if you look at the far left bar graph, if you have a certain gene, you're 100% likely to develop colorectal cancer in your lifetime. So if I'm 25 years old and I have this gene, I will not wait till I'm 45 to be screened. I will start much earlier. The same with some of these other genes. You look at the far left, it's very high. At the bottom on the right, it's not so high, but there's still risk-associated genes that cause cancer. So if we identify you, either if you've had cancer or if you have family members that have cancer, we want to know, are you in this piece of the pie or are you in the sporadic piece of the pie?
Right.
It's all about intervention.
I agree, and preventing your possibility of that developing into cancer.
Yes, absolutely.
So take me through the process of someone wanting to go through the genetic testing. Maybe they don't know what their family history is, what would that process look like with
So it varies. I mean, the genetic journey, I call it, is varied among many people. So you can start as just the random person off the street who has anxiety about cancer. But we do a thorough family history. We do a pedigree, which for those of y'all either who are pet owners or have done it in school, the squares and the circles, and we look at who in your cancer has family. Typically, it's a very detailed process. But usually the way it does present is somebody in your family is a quote event. And I call it an event because I don't know, for example, if it was myself and my mother had ovarian cancer, my mother would be the event because she had ovarian cancer, which is considered a rare cancer. So now I am at risk because it's passed down through generations. So, but the process for the average person is either your family member has cancer and come to attention with one of our oncologists or their primary care or somebody, or you have a super strong family history. We have tools that help us work you through that process to say, yes, Mary Nordberg, you're at risk, or no, Mary Nordberg, you're not at risk, and you're the population risk. But if I am not the population risk, then we're going to start looking at me a lot more closely.
Right, and so you look specifically for the genetic risk, right? Not the lifestyle part. No,
I have patients that do everything right and still get cancer, and people who do everything wrong and don't have cancer. Some of it is we have a lot of other stuff going on in our body, but some of it is genetic, inherited genetic. The reason why I'm not 6 feet tall and tall, blonde, gorgeous, whatever, because of my genetics that I got from my parents. The same thing, they passed down to me. They passed down to me eye color, hair color, height, etc. They also passed down cancer genes, other genes, etc. So sometimes genetics kind of rolls to the top and takes over. So if I am a patient and I'm like, I don't know what I did wrong. Well, you didn't do anything wrong, but part of it has to do with your genetic makeup.
Right, and you can't change that, as you've mentioned.
No,
right.
But we can get out in front of the bus, stop the bus, and then say, okay, John Doe, these are your risks. Like in the graph I showed, these are your risks. Let's kind of see what we can do to circumvent that.
Absolutely, yeah, and as you said, intervention is the most important
it's all
thing.
Intervention, early detection, surveillance.
So what if somebody is, let's say, sitting at home and they're worried that they may be, at risk for cancer and they want to have genetic testing done with you? Is this an expensive process? Take me through what that looks like.
So the process is not that expensive if you meet criteria. So the criteria are basically that, we ask certain questions, and the questions I ask are, what is your cancer family history? Do you have people in your family who've had cancer at a young age? Young age used to be 40, then it's 50, now it's probably 60. Certain histology types, and I'm not going into pathology, but certain types of cancer that rank it up as like weird cancers. Also multiple family members like mother, father, sisters, brothers, children, uncles, aunts. The farther you get away from your genetic root, then the more likely it's sporadic. So if you tell me your mother, your aunt, your mother's sister, etc., and it's all, and these pass down through family lines. So if you tell me that your mother's family has all this, and then you have one or two people on your dad's side, we'll focus on the mother's side. But the testing process is easy. So once you meet criteria, the test happens, and then we can identify you. Typically, the golden rule is, but it doesn't always happen, is we like to test an affected person first. So say your mother had breast cancer or ovarian cancer. We would like to test her first because it's all about cause and effect, right? So if I test you and you don't have cancer, but you have this risk, are you the 50% of the family members that didn't get cancer? Or did your mom just have cancer because? So it's a very detailed process. I do a thorough family history. I delve into a lot of things about patients, and then we explore every member of the family who might be at risk.
Right, and is this through gathering blood work? Is this how
we can
it's
do
possible?
blood? We can do blood. We also have, we have cheek swabs. So we
Oh.
mail these out, and this is a cheek swab just like you do with Ancestry
yeah.
or 23andMe. Same thing, you have cells. So remember, you inherit these genes, and they're in every cell of your body, whether it be your hair follicles or your blood. So for ease of patient testing, we typically sometimes will do cheek swabs. So the cells on the inside of your cheek have DNA, and you just swab it like the same reason you find out where you're from ancestry-wise. It's the same thing. We're just targeting different genes. So it's very easy. I mail these kits to family members all over the country, and they can do the test. So once a member of a family is identified, say having one of the highly penetrant genes, say BRCA1 and 2, which correlates with breast cancer, then the gene stays true in the family. So I'll mail this kit out to all the family members, and they can test themselves.
Gotcha. And so is this something that would be covered by insurance?
Yes. So if your family meets criteria, which means you've answered all the questions I just talked about, age of cancers, how many family members, etc., then family members, it is covered by insurance. It's criteria based, and there's guidelines for that. However, there is an option if you're highly anxious and you just want to know, you can pay out of pocket $250, have the test done. However, remember, and there's a caveat to that, if in fact you're negative for all the highly penetrant cancer-causing genes in these tests, doesn't mean you're never going to get cancer.
Right.
You're just not at the super high risk anymore.
That's a good point. Yeah.
So, but a lot of people like to do that, and they're like, if they're negative, woohoo, I'll never have anything. And then they wrote down to the population risk.
Right. Yeah, good stuff there. Well, if you're just joining us, we have Dr. Mary Nordberg from Willis Knighton Cancer Center. We're talking about genetic testing, specifically for hereditary cancers, and March is Colorectal Cancer Awareness Month, and so we're talking a little bit about that as well. If you're just joining us, give us a call at 318-219-4569, and you can talk directly with our doctor. Yeah, so I'm also curious, so let's say that I went in and did some testing with you, and maybe I was positive for one of the genes that you test for. So what do I do now?
So as an asymptomatic person, so you don't have cancer, but we know it's a risk game now. So say you were positive for one of the colorectal cancer genes, and your risk is highly elevated over the population 3%. So at 45, if you were population risk, we would start screening you at 45. However, if you're positive for one of the colorectal cancer genes, you're going to roll in a lot sooner. So sorry, you're going to have to do that, because now we know that you're at risk. You may not have anything, and then we need to screen you. So the genetic test is easy. As any of you who've done Ancestry or 23andMe, it's easy. You do it, you mail it in. The issue really is, once you identify as carrying a genetic predisposition mutation, or in these days it's called pathogenic variant, meaning a disease-causing variant, there is a follow-on thing you do. So I work a lot with Women's Health sometimes that does genetic testing in their office. And if you go in for your pap smear as a woman and you test, like you check the box for family history, and you're positive, it's not going away. So now you've got to see a breast specialist, colorectal, depending on the gene, all the things you have to do. So there are documented clinical guideline strategies to do. So if you came in and tested positive, then we would say, okay, Courtney, we're going to do this now, we're going to do this, and we're going to triage you to all those things. Not because you have cancer, but you have a predisposition to cancer, and we need to make sure at some level that we look out for you, because normally you would never come to attention, right?
Right.
And that's the issue.
So I have a personal interest question. So my great-grandmother had colon cancer. So since she was my great-grandmother, is that at all of a concern?
So do you meet criteria by that alone? No.
Okay.
So she's far enough removed from you, and it depends on her age. So for example, I saw someone earlier today, their daughter had breast cancer at 26. That's a huge red flag. I mean, we're raising this flag because cancer is a rare disease. I mean, I see it a lot. doesn't happen to everybody, and it doesn't happen to everybody in your family. So if you start, historically, we never talked about this publicly in our families. I mean, nobody wanted to talk about, especially female cancers, all that kind of stuff. So, but now we're kind of in an information age where we share information. So having said that, okay, that's good. But if you explore your family a little more, you might find that your great-grandmother actually had siblings that had a bunch of cancer, or your mom might have been the 50% that didn't get the gene, but her siblings did. So when people actually think about their families and ask their family members, well, what happened to Grandma Jane? What happened to Aunt Sue? They realize, well, she had something, we don't know what it was. But so technically you don't meet the criteria based on that alone. However, we can explore it more. That's what I do.
Yeah, and also just having that peace of mind too, of just going through and seeing the hereditary risk that you might have is pretty interesting.
It is, and it is 20% of all the patients that we test in the Willis Knighton Cancer Center actually carry a predisposition gene. And if you look at it, if you have cancer, 1 in 8 people of the cancer patients have a predisposition gene that we may or may not know about. But if you use family history alone, our families are smaller these days. Again, we don't talk about stuff. So you can't just rely on family history to say, oh, you're going to have to be tested.
That's a really good point as well, Dr. Nordberg. And I think we have someone on the line. Carl, what is your question for Dr. Nordberg today?
Say if someone has cancer and they're concerned about it being passed down to their progeny, what would you recommend? At what point should that person come in to be tested, or exactly what's the procedure?
So, Carl, it's pretty straightforward. So if your family member has cancer, again, remember it takes an event. So the event is the person who has cancer that presents. So if your family member has cancer and he's worried about passing it on, again, a couple things apply. It depends on his age, it depends on the type of cancer he has, etc. But he is eligible, he can be tested, and then if he is positive for any of these genes that we test for, then everybody alongside of him and down below him actually are eligible for testing free of charge if he does have a genetic change. Now, he may just have cancer because, go ahead.
I was going to ask, how does one go about getting the testing then? What's the procedure for that?
The procedure is, so at the end of this talk, we do have a QR code that kind of lets people scan it, and then it comes to me. You can call me, you can call Willis Knighton Cancer Center, set up an appointment. I will vet the patient for whether they're eligible or not eligible for testing. And it's that simple. It's that simple. And insurance does cover it if the patient meets criteria. Again, you can do a self-pay if you're really concerned about it, but I can help the patients work through the process to make sure that they get the testing they need and then they get the care they need after the testing.
All right. Let's say the person tests positive and that there's likelihood that it would be genetic. What does their offspring need to do? What can be done for them after we know it? Knowing it's one thing, doing something about it is an entirely different thing, though.
So if your relative who has cancer tests positive, and again, you can have relatives who don't have cancer that test positive, okay? So that's also the value. Mm-hmm. So everybody, remember, it's dominant gene, so it passes down through generation. So the family members of that individual, both siblings, offspring, nieces, nephews, cousins, depending on the whole dynamic, are eligible for testing once a mutation is identified in a family. So once a mutation, and there's lots of mutations, and I don't have time to go through that today, but once a mutation is identified in a family, it stays pretty true to that family. So say you have an ABC mutation, everybody in the family would likely inherit the ABC mutation. I'm just making that up, but it's a fairly easy process. So you can do the QR code, which actually does an intake on family history. You can call, you can set up a time. You don't have to be seeing an oncologist necessarily at Willis Knighton Cancer Center. You can see me first, you can see me after, you can see me during. Whatever the process is, we make it easy for patients to be able to be identified and tested. Because what we don't want to do is miss people who carry these mutations, and God forbid they're walking around with mutation and then they get cancer, and we're like, oh, shoulda, woulda, coulda done this 10 years ago, and I would have been out in front of it.
Mm-hmm.
Well, I guess the point I was trying to get to is what can be done for them what sort of preventative
management
actions to be taken to keep getting or cancer presenting in the offspring or a sister or brother, whatever.
So let's take colorectal cancer. So the guidelines are now 45 years old, okay? So say I identify a colorectal cancer mutation in your family member, okay? Well, the offspring siblings may not wait till 45 to be screened. Now they're a bona fide card-carrying member of the genetic club, so to speak. They can start screening earlier. So it's not just colon, breast, ovarian, pancreatic, other things that the patients actually qualify for that they would not qualify for if they were just general population. Does that make sense?
I see. Yeah. So actually the preventive measure is actually screened earlier and earlier.
Yep. And many oncologists will, even if you have cancer, and I'll just throw this out there, even if you have cancer, a lot of my patients will say, well, why do I need to be genetically tested? Well, because one, if you have one cancer, remember it's every cell of your body, you can have another cancer, completely another cancer, multiple. So even if you have cancer and you identify as a positive patient, then your oncologist may stratify you a little bit differently than the person who doesn't have a genetic change.
I see. Okay. Well, listen, thank you very much.
Thank you for calling, Carl. We appreciate it. Thank you.
Yeah, thank you very much. And if you are just joining us and you had a question for Dr. Nordberg, we're talking about hereditary cancer and genetic testing. And give us a call at 318-219-4569. So I did have a question after that, and this might be getting into the weeds of it, but let's say like my mom had breast cancer and I did the genetic testing. Is there a chance that I wouldn't have a positive result of that specific mutation? Or?
So if your mom had breast cancer and has a mutation, so she has bad gene, good gene.
Okay.
Every time she procreates or has a child, it's heads or tails. She can give this one bad, or she can give this one good.
Right.
So it's 50%.
Okay. That's what I was thinking from biology or the pedigree, right? Yep. So, but you just never know. And
well, you don't know. So if you're negative, then you roll back to population risk. If you're positive, though, we're going to move Courtney to a whole nother path for clinical management.
Gotcha.
But if you're negative, doesn't mean you're never going to have breast cancer, but you're not up here, you're back down here.
Makes sense. And I wanted to explain that again because I think that's important. Well, Chris is on the line. Chris, what is your question?
Yes, good afternoon. I've often wondered, and I've not heard you mention anything about the pancreas or the liver, why there is not screening for those two areas, which seem to be a high mortality rate if you get it, and they never find it out soon enough.
So, Chris, I mean, it's a complicated subject, but the bottom line is we don't typically screen. So mammography is what we do for breast cancer. We do PSA for prostate cancer. We do colonoscopies for colon cancer, okay? So now if you come to me and tell me everybody in your family has pancreatic cancer, regardless of genetics, we may screen you a lot more stringently. However, if you have one of these predisposition genes, for example, BRCA1, BRCA2 are associated with an increased risk of pancreatic cancer. So you may be fine, healthy, whatever, but if you're positive for those genes, it may allow you or push you into being screened for pancreatic cancer because we know your risk. So pancreatic cancer is rare, liver cancer is relatively rare, so that's why breast cancer is pretty not rare, it's pretty common. Prostate cancer is pretty common, and that's why the U.S. Preventive Task Force sets up we have screening algorithms for that. Pancreatic, again, you're right, you don't know you have it sometimes until you have it, but if you have a family history or you carry a predisposition gene, we're going to screen you a lot earlier, and so that's a decision from the medical team to say, okay, we're going to screen you, Chris, because you have this gene which predisposes you to pancreatic cancer, and we're going to screen you because of your family history. And that's how you get vetted into the screening algorithm that may or may not be for the general population. So like if I say, oh, I saw Alex Trebek died of pancreatic cancer, I'm freaked out about pancreatic cancer. I mean, I really don't meet the criteria because I don't have a family history of pancreatic cancer. However, if I'm carrying one of these genes that predisposes me to pancreatic cancer and I'm freaked out about pancreatic cancer, then the rules change just a little bit. And that's where the screening for genetics comes in, because we do know that certain genes elevate your risk of pancreatic cancer. BRCA1, BRCA2, another gene called ATM. I'm not going into this, but that's where genetic testing can help guide your clinical management so we can prevent you from getting cancer, because now you're being screened, whereas the general population is not. Does that answer your question? Okay.
All right. Well, thank you, Chris, for your question. And if you have a question, we have just a couple minutes left, 318-219-4569. And I'll get back to my questions. Well, let's say that I already have cancer and I've just been diagnosed. Does genetic testing still benefit me at this point?
Yes, as I mentioned earlier, so it's every cell of your body, right? So just because you've had one cancer doesn't mean you're not going to get another one. So if I have breast cancer, for example, and I have a BRCA1 gene. Okay, so fine, I take care of this cancer. I do whatever my doctor tells me to do. That doesn't mean I'm not going to get cancer in the other breast. That doesn't mean I'm not going to get cancer in another organ in my body. So does it help you? Yes, it helps you to guide you through management. And so my patients, even young patients, like I have 25-year-olds who have these predisposition genes who are like, I don't want to do all this stuff. But you have to be on a timeline. You have to know that, okay, in 2024, in March, this is where I am. And I know that my risks increase every year. So it is just something, and I hate to say it, but it's like an albatross you carry around because you know it's coming. Mm-hmm. How do you keep it from coming?
Right. And so tell me a little bit about the importance of, we're talking about intervention and prevention and management. So tell me the importance of getting these genetic testing, like the outcomes maybe of catching this cancer earlier. Are you at a better outcome of surviving this cancer?
Well, yeah. So if I say I'm a 30-year-old woman and I have a BRCA1 mutation, or say I'm a 30-year-old woman and have a colorectal cancer associated mutation. So I'm going to start screening my colon at 30. So remember, I can remove my breasts preventively. So if I have a highly penetrant gene that predisposes me to breast cancer, so I may choose, this is a patient choice, I may choose to have a preventive surgery. And if I do preventive surgery, then my risk goes boop, way down. The same with hysterectomy. If I'm done with having my children, or even if I'm not done, but I need to keep it in my mind that maybe taking my ovaries out is beneficial, because then I won't get ovarian cancer. Same with colorectal. I'm going to start screening because I don't want those polyps growing in my colon for all this time. And now I'm going to start screening at 30 instead of 45, because in that 15 years, I may actually develop colon cancer.
Right, and a lot of these cancers are asymptomatic, and you don't really know it's bad until it's really bad. Yeah.
Yep.
So tell me, we've got a QR code that we want to put on the screen for our viewers so they can scan it, and tell me what this does.
So the QR code actually is called, it's a My Gene History. So you basically input things in the QR code that basically comes to me directly, doesn't go anywhere else, and it basically says, do I meet the criteria? So you enter facts about your personal history, you enter about your family history. It all comes up to say, yes, am I a candidate for genetic testing? And that's okay. If you're a candidate and you meet all the guidelines, that's great. But even if you don't meet all the guidelines, that doesn't mean you can't do genetic testing. It's a tool for us to use to explore your personal and family history of cancer. And that's really what it is, because people all over the city, all over the state, actually send me these QR code answers and then we decide, yes, Ms. Smith, you need to come in. And then I call you and I say, do you want to come in? And sometimes people say, no, I just did it because I was bored.
Yeah, right.
But
Give us real quick the phone number that we can contact.
so the phone number, my direct phone number at Willis Knighton is 212-6214.
Awesome.
212-6214. You can
Easy.
email me
Yep.
at Willis Knighton. However, I'm
Awesome.
more than happy to meet with y'all.
Thank you, Dr. Nordberg.
No, thank you.
We
Thank
hope you have a happy and healthy day.